Well, happy to be with all of you today at the end of the day. Hope we've still got a little attention span left. If not, you should do a little wiggling around like I've been doing. I enjoyed Maureen's talk. I'm going to be talking to you about psychosocial issues and inflammatory bowel disease. I am a gastropsychologist. I'm an adult GI psychologist. I work at the University of Chicago. And so actually just kind of in line with some of the questions that just came up in the chat, what I'll say is that I think that I'm definitely speaking to the field of psychogastroenterology more broadly, though there are some pretty significant differences in practice between adult GI psychologists and pediatric GI psychologists. There are going to be some things that my talk may not speak to as well, and I'll do my best to answer questions, but I may just have to defer you to a pediatric colleague and could always get you in touch with someone if that felt useful. All right, so there are some people here today at this discussion that may work with a GI psychologist, that may be very familiar with it. But if you're like most folks that I'm talking to, there is a large proportion of folks here that actually had never heard about GI psychologists or the field of psychogastroenterology until right now in this moment. So I want to give you a little bit of a primer as to what that is and what I'm referring to. So I'm going to actually just start with briefly describing clinical psychology as a way of then understanding psychogastroenterology. So when we're talking about clinical psychology, that is it's the only field of psychology where psychologists are not only doing research, they're actually doing clinical work, they're doing patient care work. So these are the types of psychologists that are actually providing psychotherapy to patients, or they may be, they're at least trained to do that. These can be people with PhDs in clinical psychology, or they could have a PsyD, which is still a doctorate in clinical psychology. It's just a more professional rather than research degree. Within clinical psychology, as you could probably figure, people can specialize in all kinds of things. They could specialize in OCD, or severe mental illness, or substance abuse. One of the specialties that people can go into would be health psychology, people that are really working with health and medical populations, focusing more on aspects of physical disease. And within that, folks can choose to subspecialize further if they want to. So subspecializations could be health psychologists working in oncology, health psychologists working in weight management or smoking cessation. I'm a health psychologist that subspecialized in psychogastroenterology, which is then really referring to the field of practice, both clinical and research practice, pertaining to patients with gastrointestinal disease. So we call that psychogastroenterology as its full name. Sometimes we call it gastropsych or GI psych for short. And those of us who are clinical psychologists doing this work typically refer to ourselves as gastropsychologists or GI psychologists. So just to give you a sense of this field and specifically the perspective that I'm speaking to today. So probably most of you are familiar with the gut-brain axis, and this is really the idea that the role of a GI psychologist is predicated on, is really this understanding that our gut is not working fully independently, and our brain is also not working fully independently of our gut. The gut-brain axis is really a two-way communication pathway that exists between the enteric nervous system, the nervous system of the GI tract, and then the central nervous system, our brain and our spinal cord. It's a very complex system that involves the microbiome, the neuroendocrine and immune systems. But what we know is that our gut is constantly sending information up to our brain. Our brain is constantly sending information down to our gut, but that most of the communication between the brain and the gut actually occurs when we're stressed. So when we're not stressed, when we are in a state of relative relaxation, our gut and our brain are talking kind of like this, and that's good. They actually can do a lot on their own. But when we become stressed is when our gut and our brain are talking a lot more closely. They're talking like this. And so this is really one way in which we see gut-brain dysregulation being a problem for not only patients who have disorders of gut-brain interaction, sometimes called functional disorders, but we also see this in our patients with IBD. I'm telling you this in this way because this is exactly how I talk about it with our patients. So I'm hoping that some of the modeling that I'm going to do today in terms of psychoeducation can also be helpful for you to be able to apply this when you're speaking to your patients. So I'm going to talk broadly today about psychological and social issues in IBD. You'll notice that I don't have my presentation titled as mental health concerns or mental illness in IBD. What I want to talk about more broadly are issues related to psychology and to social factors that can impact our IBD patients. And then I'm going to go kind of into a few of these, not all of them on this slide, but I'm going to narrow it down a little bit more to a few of these that I think are the most important for you to know about, or that are some of the ones that are lesser known, that I think may come as a little bit more of a surprise to you, or you might not be as familiar with. So just on this slide, I have a whole range of things. You can see that some of them are more classically psychological, like anxiety and depression. And then we have things like body image and fertility and trauma that we actually think about more in kind of that social domain. So together, that's psychosocial. It's really anything but the purely biomedical aspects of a person's health or disease. So I'm going to start with depression. Now, depression is one of the things that you all are very accustomed to talking to your patients about. I know this because I work very closely with my APNs. And so you're oftentimes asking about this. What I also wanted to make sure to speak to today was just rounding out your understanding of depression a little bit more, perhaps. And again, modeling how you might talk about this with a patient. We talk about depression and anxiety all the time, but you actually might be surprised by how many questions patients will really have about what you mean when you talk about depression or anxiety. We all, as healthcare providers, probably have a good understanding of it, but many of our patients actually don't really know what you're referring to when you ask, have you been depressed? Have you been anxious? So again, we're hoping to round that out today. So what is just, first of all, the definition of depression? Well, the definition is that it's a persistently depressed or sad mood or a loss of interest in activities. Doesn't have to be both of those, it just needs to be one. Common symptoms of depression could be things like trouble sleeping, changes in appetite, hopelessness, guilt, difficulty concentrating, and suicidal thoughts can be part of it, whether passive, something that they're not going to act on, it's just kind of occurring to them that it'd be easier if they just didn't wake up the next day, or it could be more active suicidal thoughts where they're making a plan and they're thinking about really carrying out. Now, actual diagnoses for depression, there are actually several of them. Some of the most common ones that we might see would be major depressive disorder, which has all kinds of nuances in terms of whether it's recurrent or a single episode or mild, moderate, or severe. As well as an adjustment disorder, which I find that many of my medical and nursing colleagues haven't heard about before. So an adjustment disorder is technically, it's a mental health diagnosis. Thank goodness we have it because it allows for us to bill insurance for psychotherapy sessions with many of our patients. But really what it's saying is that this is a person who's having a psychological reaction to an acute stressor in their life, and it's sort of above and beyond what we might expect. So we might say that a patient has an adjustment disorder with depression or an adjustment disorder with anxiety, as you'll see later. And that's one of the most common diagnoses that I list for our patients with IBD, because our billing system does put a preference on putting a psychiatric diagnosis as a psychologist doing the billing. So in IBD, about 25% of people do struggle with symptoms of depression. Doesn't necessarily mean an actual major depressive disorder, but substantial symptoms. And then that goes a lot higher when you're looking at people with active disease, so actually closer to 40%. What are the ways that depression manifests in clinic, even if a patient isn't specifically talking about their depression? Well, we should be thinking about if depression is playing a role for our patients that are missing their appointments, for our patients that are missing our phone calls or are not reading the messages that we might be sending through their electronic medical record, for the patients that might present as angry or irritable or very sad. And then they're the folks that might be really struggling to take their medication, to present, for their infusions on time, those kinds of things. Now let's talk about generalized anxiety. So generalized anxiety is an emotional state that's characterized by tension in their body, worried thoughts, and physical changes. Some of the most common symptoms that we might see would be nervousness, irritability, GI upset is a symptom of anxiety, and as well as other physical symptoms like sweating. Generalized anxiety disorder would be one of the most common, but if you see, for example, a patient that tells you about only having anxiety about social situations, that's actually a separate anxiety disorder called social anxiety disorder. And adjustment disorder, again, can apply here and oftentimes does for our patients with IBD when it's more of an acute reaction. So about a third of patients with IBD do struggle with anxiety, and that gets a lot higher when we're looking at active disease. That's closer to 60%. So what does this look like, you know, in the patient that might be sitting in front of you? It could be a patient that's looking nervous, jittery, overwhelmed. They're talking a lot. They have elevated blood pressure. Maybe it goes down at the end of the visit after you check it again. They're the patient that might be doing the excessive online researching, or in contrast, they might be avoiding what's causing them anxiety. They might be avoiding phone calls or not going to their medical appointments. They could be extremely worried about side effects of medications to the extent that they're not willing to start new medications. And they also could have phobias or aversions, like problems with getting an injection because of being afraid of needles or having trouble swallowing pills. And these are some more specific types of anxiety presentations. So next I'm going to talk about GI specific anxiety. This can certainly overlap with generalized anxiety, anxiety that can be about all kinds of things, but GI specific anxiety is a construct that we see a lot within our GI and then of course more specifically IBD populations. GI specific anxiety is not associated with a particular diagnosis like generalized anxiety disorder, but it is the most common thing that I'm treating in my clinical practice as a GI psychology. So we define this as fearful and anxious thoughts and behaviors that are related to GI symptoms or the context in which they occur. So worries, what this might look like in a patient's mind, could be something like, oh no, why is my poop that color or that shape? Which we then should translate to something dangerous is going on because my poop is green right now. Could be a worry like, if I have to have surgery, my life will be over. It could be, I'm having belly pain, so I better play it safe and skip that dinner tonight. Behaviors could be, again, going back to those maybe more excessive EMR messages. It could be excessive phone calls, doing the excessive researching of their symptoms. It could be patients having a highly controlled diet or maintaining a really rigid toileting routine. Or again, it could be in contrast, those patients avoiding their medical appointments or testing because they're afraid of what they might find out and they're assuming it could be that worst case scenario. Disordered eating has been talked about quite a bit today, which is great. I love the fact that we're clearly doing so much integrated care here because so many talks we've had already have referenced psychosocial concerns. But, you know, disordered eating is basically referring to a number of different eating behaviors that fall outside of what would be expected and what would be adaptive and healthy. So it could be binge eating, it could be skipping meals, it could be avoiding certain types of foods. These are not necessarily fueled by body image concerns, though they can be. They're in fact often motivated by fear and anxiety related to eating certain foods or just being able to have this perception of control. There's so few things with IBD that a patient can control, and if they can control what they're eating, sometimes that just psychologically feels good. Now, when severe, disordered eating could elevate to a psychiatric condition, a type of eating disorder that we call avoidant restrictive food intake disorder, ARFID. But don't forget too that anorexia nervosa, bulimia nervosa, these are very common eating disorders. And so ARFID is not the only eating disorder that you should be paying attention to in a GI clinic, though it is one that I would say has gotten a ton more attention in the last several years. So body image concerns are going to be very common in this patient population. The ones that I think are most common would be, you know, because they're experiencing unexpected or weight loss or weight gain, as many of you probably have also seen. You know, once a patient has gotten to a point of remission, it's really weight gain that is oftentimes more of a problem, and that can make them extremely self-conscious. especially because there still is this perception that, oh, the typical Crohn's patient is underweight, and they think, wow, there must be something really wrong with me that I'm struggling with obesity. And of course, that's just not the case. A lot of our folks are going to be having some difficulty, even for some time, adjusting to living with an ostomy and what that looks like and feels like, and how they navigate social relationships and dating and sex with that. Or simply fear of having an ostomy. Folks that don't have an ostomy right now, but live in fear about what that change could mean for them. And then perhaps most commonly, again, in my practice, would be simply embarrassment about bowel issues, embarrassment about passing gas, about incontinence, about being in the bathroom a lot. These are all things that we put it under that umbrella of body image concerns. Sexual dysfunction is a specific area that I specialize. I'm a certified sex therapist. And so I do a lot within, with our IBD patients and helping to address issues related to sexual function, which can be really, as you're seeing here, it can be really common in IBD. So what is sexual dysfunction? It's referring to any problem that occurs within the sexual response cycle that cause a decrease in satisfaction with sexual activity. So this could be having painful intercourse, having a low sex drive, having difficulty with erections, or an inability to have an orgasm. In IBD, the rates vary really widely. And of course, there's just a huge range in how these are studied, including whether we're looking at patients with active disease or not, how newly diagnosed they are. But at this point, the rates within women are anywhere between 50 to nearly 100%. That 97% was women who have been diagnosed within 1 year, by the way. And in men, the rates of sexual dysfunction range from 14% to 40%, so still very high. So what does this look like in clinic? Well, it rarely does present in clinic because, as the data suggests, we hardly ever talk about it with our patients. But when we do ask, we hear about things like medication side effects. Even when we don't have a lot of data supporting that medications actually directly cause sexual dysfunction, many patients worry that they do or perceive that they do. Embarrassment about bowel symptoms, self-consciousness about scars or about new aspects of their anatomy, and largely about pain and fatigue getting in the way of having any interest in sexual activity, which is, again, we would expect that. Because someone else earlier today had said that if you're tired, and you're not feeling well, then you're probably not going to be interested in sexual activity. And then finally, trauma is an area which is also has been talked about quite a bit in the last few years. So when we're talking about trauma, we're talking about post-traumatic stress or post-traumatic stress disorder, PTSD, that's really related to the medical illness and treatment. We call that medical trauma. That's also not to say that our patients with IBD can't have trauma related to other experiences in their life, witnessing violence, sexual assault, neglect, right? But it just means that we need to be mindful that our patients are at even increased risk because they have the same risks as any other person having a background, including trauma, but then their IBD experience also puts them at greater risk. So the symptoms that we can see there would be what we call re-experiencing symptoms, having memories that sort of just come up all of a sudden about maybe a surgery experience, or having uncontrolled pain while in the hospital, having nightmares or flashbacks, avoidance, so like avoiding thinking about that experience that they had, or avoiding going to the hospital where they had that emergency surgery. They can have negative changes in their thinking or their mood, like thinking negative things about themselves or others. And then they can also have an increased arousal, so like an elevated startle response or difficulty sleeping. This is an emerging area of research in IBD. In a 2019 study, it was found that about a third of patients with IBD did score above a clinical cutoff. It's a PTSD screener. And then in a subsequent study, almost 10% did meet criteria for a post-traumatic stress response that would be really specific to their IBD. And this was using our psychiatric criteria for PTSD. So that does not necessarily, these are people that would really need to have a full clinical evaluation to fully determine that diagnosis, but that gives us a pretty good indication that 10% are really having clinically significant symptoms associated with a prior trauma related to their IBD. So in clinic, what might we see? It could be patients that are just declining treatment altogether. It could be folks that are avoiding coming into the hospital or clinic space. Again, not responding to phone calls. Could be patients that are more jumpy, easily startled, angry, and I think a big one, mistrustful of providers. Oftentimes, whether warranted or not, the medical team can bear the brunt of sort of the patient, maybe who the patient feels like could be at blame because of the the difficult traumatic medical experiences that they had. So very good to keep in mind if you have a patient that's quite mistrustful, you should be thinking about trauma. So I want to talk more about assessment of psychosocial issues. This has been talked about already, but I think I'm hopeful that I'm coming at it from just a slightly different lens. So what I want to talk about mostly is how to use your clinical interview, how to actually just use your conversation to assess for psychosocial and in particular mental health concerns. So validating the concern and building the relationship is one benefit of using a clinical interview approach to assessment rather than simply giving a PHQ-9 or a G87, which I will talk about next. If you can provide strategies for what they can do to address this psychological or social problem, then of course that's going to be best to do right in the clinic visit. And it might require setting up another appointment to discuss this further or to provide appropriate referrals if needed. And as Maureen discussed, it is really important to make sure that the primary care provider is looped in here. And I sometimes find that our IBD patients, it can actually work really well to loop their primary care provider back into mental health treatment, for example, because at some institutions, the IBD team may not have the bandwidth to be managing that, whereas bringing that back to the primary care team can sometimes be a good way to go, especially if you don't have the presence of psychology in your department as well. So when I talk about the clinical interview, what am I talking about? How might you ask this? It actually could just be really simple. And quite honestly, it's probably stuff that you're doing already. So just a question like, how are you coping with everything? Very open-ended, but see how the patient responds. You might then ask something that's a little bit more focused. We call this kind of a more permission-giving technique where you're kind of inviting the patient to say, yeah, no, that is a problem for me as well. Something like many people with IBD experience changes in other areas of their life as a result of their illness, like problems with their eating or sexual functioning or a lot of fear or anxiety, what it could mean for their lives. The things that I'm mentioning, is anything like that happening to you? Have you noticed any changes like that? So listing a few examples can help normalize it, that, oh, okay, I'm not the only one that's dealing with this. While these psychosocial concerns that I listed today seem like probably no-brainers to you all, our patients oftentimes are living in isolation and they are not privy to the 15 patients that you're seeing each day, that many of whom are talking about issues like this. I've actually had a patient with ulcerative colitis. It wasn't until an appointment that he had with me that he learned that other people with ulcerative colitis struggle with incontinence. He was someone that had had ulcerative colitis for many years and thought that that was a really unique symptom that he had. So I just say that to say, don't assume that things are obvious to our patients. They oftentimes live in isolation, whereas we don't. We have tons of numbers to be able to normalize these symptoms. So then going to self-report measures, and these have already been mentioned by others, but there are some benefits then to using self-report measures. These can be really quick assessments of psychological distress. They're a nice, easy reference for symptom severity because they have cut points that tell you, oh, this is minimal, essentially normal, this is mild, this is moderate, so on. If you give these at every visit, it allows for us to see changes in those symptoms over time. But it can be quite burdensome to actually administer these questionnaires and get them typed in the note. And it also, I think one of the concerns that I have is that sometimes this can be a replacement for having a conversation with the patient. And these questionnaires are not meant to be just given to the patient and then forgotten about. They really need to be followed up with a discussion, reviewing the patient's questions, reviewing and then making reviewing the severity and then making some recommendations. So the questionnaires that do have the highest validation in IBD specifically would be the PHQ-9 and actually the PROMIS anxiety, which I have listed second. But I will say in my own practice and for most people, the GAD-7 is just so easy to use. It's easy to score. So my actual recommendation is to go with the PHQ-9 and the GAD-7. And by the way, I should say to the last slide, these are really close. They're still really good validation for using the GAD-7 in IBD. So when we think about providing referrals to our patients and follow up, I like to think about two different kind of main referral pathways. One would be what we'd think about as more brain-gut behavioral therapy, and one would be more general mental health therapy. So brain-gut behavioral therapy is really like a technical name for what I do. I sometimes call it GI-specific psychological treatment, GI-specific psychotherapy, but brain-gut behavioral therapy is really referring to the type of work that a GI psychologist does. So if you see a patient that you think, wow, like stress really seems to be playing a role in their symptoms, I think that even though they're in pretty good clinical remission, it seems like there's some things related to their lifestyle or again, some of these psychological and social factors that might be maintaining their ongoing diarrhea or abdominal pain, then you would refer to a GI psychologist for behavioral symptom management. We're going to be actually using psychological and behavioral strategies to try to help the patient reduce their GI symptoms. You also might refer your patients to a GI psychologist to just help them cope with and adjust to any number of IBD related concerns. So that could be some mild to moderate depression or anxiety. But that is really going to be most effective. If it's anxiety or depression, that's pretty closely related to their IBD experience. I say that because most GI psychologists, since there's usually very few of us, for me, I'm the only GI psychologist at my institution. I've got a tremendous wait list. We see patients every other week rather than weekly. So we really need to see patients that have a pretty good psychological stability, and we're really working on retooling how they're coping with their IBD. Again, this varies widely. If you have a GI psychologist at your practice, they may see patients weekly, but that's pretty common. Is a slightly different practice than a traditional mental health psychologist or other therapist. So then going to that, general mental health therapy is still very appropriate for many of our patients with IBD. So this is going to be more appropriate for our patients with IBD that have a lot of family turmoil, that have a lot of financial stress in their life, things that is not necessarily related to their IBD, even if it might be impacting their ability to cope with IBD. It could be patients that have quite severe anxiety or depression, or they have something that requires more specialized treatment. They are struggling with alcohol use, they have an eating disorder, they have PTSD. These are areas where certain psychologists or other types of mental health professionals have gone on to get advanced training in that. I went on to get advanced training in GI. I didn't go on to get advanced training in substance use or PTSD. So I might be able to be of help evaluating those patients and saying, no, I think they really need a general mental health psychologist or other type of therapist. But if you can make that distinction yourself, which you are, like, odds are good you can, then in that case, you would actually be better off not referring to a GI psychologist, even if you have one available to you, but you'd really be better off finding a general mental health provider in your community or at your institution that you can refer to. And of course, I'm focusing more on psychotherapy today, but of course, you also don't want to ignore the possibility of medication management, which you may feel comfortable doing on your own, or you may want to refer back to primary care for, or to a psychiatrist. So I want to also just talk about how your own practice can be therapeutic. It may not be doing psychotherapy, but you can bet that it's an intervention when you're doing it well. And I'm guessing that this is preaching to the choir, because I'm going to guess that many of you, all of you probably are doing a lot of this already. So it's just really just to highlight the good work that you're already doing. So things that you can do to make your clinic visit therapeutic for that patient, for your patients, would be optimizing body language. stretch, making eye contact, leaning in. Even if you're typing as you go, most patients get that that's the reality now, but taking breaks where you can pause, look them in the eye, lean in, those are things that really do make a difference. Validation and normalization are two kind of soft therapeutic skills that anyone can use. So validation is just making a person feel that their experiences are real and that you are telling them, yes, I know that your experiences are real. So saying something like, wow, I hear how much this is impacting your life right now, right? Or I hear how much you're suffering. I understand how hard this is for you. Normalization, we talked a little bit about earlier, making a person feel like they're not a freak for what they're going through, saying something like, this is a common experience for many patients that I work with. And this is tremendously helpful when you talk about bowel symptoms like incontinence or sexual dysfunction, issues that in which we have a lot of stigma as people. And so really going out of your way to normalize those and say, you know what, this is part of the IBD experience. Not to say that, of course, we don't expect that to get better, but in this moment in time, when your disease is not well controlled, this is a thing that many people struggle with. Providing education, such as education on the gut-brain axis, like I did earlier today, is just one way of explaining why our mental health impacts our physical health. And then always important to assess for lack of information. Sometimes the best treatment for anxiety is education. Sometimes when patients repeat questions over and over again, what they're really telling us is that they don't know the answer to something and they need it explained again or in a different way. And usually if we do that and they're still asking the question, that's when we have a sense that this could be driven more by anxiety rather than a lack of knowledge. So a little bit more about providing education. So again, talking about the gut-brain axis, talking about the relationship between mental health and just generally psychological and social factors in IBD. If you're going to make a referral, make sure that you explain why it is that you're making that referral. Is it for more general mental health factors? Is it because of these more IBD specific factors? And also, if you might be considering prescribing a medication such as amitriptyline to help with abdominal pain, talk about them, refer to them as a central neuromodulator rather than antidepressant. It's very helpful to be distinguishing between if we're using a psychotropic medication for a mental health reason versus a GI symptom reduction reason. This is some of the language that can just be very helpful. It can decrease stigma, it can improve understanding. So it's just a recommendation that I would make. I'm going to just talk a little bit briefly about what the type of therapy is that I do so that you have a sense of what that looks like. So there's a number of brain gut behavioral therapies that have been studied and have good evidence behind them. The most common are CBT, gut-directed cognitive behavioral therapy, and gut-directed hypnotherapy. CBT I'll talk about first. So this is really based on this understanding that it's our thoughts and our behaviors that impact the way that we as people feel, both physically and emotionally. So when we think about this for our IBD patients, let's say that they're having pain after eating lunch one day, they might have the thought, oh no, the last time I had pain like this, I was having a flare. What's that going to result in? A change in emotional state. They're going to probably feel anxious and fearful and maybe even sad. That causes a change in our body. That's our sympathetic nervous system responding, our body stress response, which actually worsens pain and it worsens GI function, leading to then perhaps worse pain and maybe now even diarrhea. How a person behaves, how they respond, right? These are the coping strategies, whether good or bad. Do they miss work the next day? Do they call their doctor immediately? These are things that can be helpful, neutral, or harmful. And then if this goes unchecked, it can actually result in worsened symptoms. So these are the types of things that I might actually parse out. I'm focusing with patients on shifting their thoughts, shifting their behaviors, and then also working on teaching them relaxation strategies so that they can de-escalate their body and their mind when they are in a state of extreme stress. GI CBT is typically short term, so I'm not working with patients forever and ever. It might be 4 to 8 sessions. Again, it's really based on the patient's preferences and presentation. This can really look different from patient to patient. So in IBD, a patient may not be coming to me for any help with their GI symptoms. It really might be all about coping with the stressors that they're under because of living with their IBD. Hypnotherapy, I kind of joke, it's not as weird as it sounds. Clinical health psychologists use hypnotherapy pretty frequently to help with chronic pain issues and other types of physical discomforts. It's a process by which a person can enter a heightened state of relaxation and attention, both at the same time, that can make them more open to suggestions about physical changes in their body. In IBD, we find that it's really helpful for reducing hypervigilance and hypersensitivity and improving self-efficacy and relaxation. Just a little bit of a note in pediatric populations, as I've acknowledged, I can't say too much, but this is going to be really about working with children and their families to learn strategies for managing IBD, particularly when we're talking about younger children. You're rarely going to be working with a child alone. This work is going to be done in conjunction with the whole family. It's typically going to be family therapy. It's going to be about learning coping skills, including relaxation strategies, just like I might use with adults, including hypnotherapy, by the way, that can mitigate the effects of stress on the body. It's about improving social and occupational functioning, especially return to school or finding accommodations if needed at school. And of course, there's that eventual support in transitioning self-management into adult GI care. So in my slides, I have listed some resources. I did try to include some pediatric resources as well where possible. You'll see that my second list here is a directory for finding GI psychologists in your community. Thankfully, a lot of this work, almost all of it, is done virtually nowadays. So there are some rules around interstate practice, but there are some possibilities for that if you live in a state that does not have a GI psychologist. We also have some ability, APNs can do a lot of this type of work and can be a huge support to us. So please keep in touch with me. I have some training organizations that you can look at. And these are patient-facing resources. So we have a really nice book written by a GI psychologist about coping with Crohn's and colitis. It's based on a CBT model for IBD. And then there are some apps as well that can be pretty helpful. I did include one for IBS because our IBD patients also like using that too.